Thank you so much for joining us for the ACRO webinar, GammaTile Therapy, Brachytherapy Powerfully Reimagined. Tonight's webinar is going to be led by Dr. John David, who is the Director of Brachytherapy Services and the lead physician of radiopharmaceuticals at Tampa General Hospital. Dr. David is a board-certified radiation oncologist, and in addition to GammaTile therapy, his interests include stereotactic radiosurgery, intensity modulated radiation therapy, and stereotactic body radiation therapy / stereotactic ablative radiation therapy. Prior to joining Tampa General, Dr. David was fortunate to work with physicians at the New York Proton Center, gaining experience in one of the most contemporary radiation treatment modalities, proton therapy. Dr. David graduated from Wayne State University School of Medicine in Detroit, Michigan, and served as the chief resident of radiation oncology at Cedars-Sinai Medical Center in LA. Dr. David did additional brachytherapy training during externships at Memorial Sloan Kettering Cancer Center in New York City and Kaiser Permanente in Santa Clara, California. So that is quite an introduction. And I will, without further ado, turn it right over to Dr. John David. Thank you so much for being here.
Thanks for having me. I really appreciate everybody coming out today. I know it's middle of the week, so I won't belabor too much, and I'll try to keep this as interactive, as fun as possible, and concise as well. So we're obviously all here today to talk about GammaTile therapy, surgically targeted radiation therapy for patients with brain tumors. I participate with Quantum Cancer Centers, Veracyte, and obviously GT Medical today. Obviously, the discussion today is about brain tumors and this unmet medical need. We know that brain tumors can have a high recurrence rate, given that, surgery is the mainstay of treatment, but, surgery can be difficult as, we want to spare healthy tissue of the brain with removal. So there's really not a true margin as we think of in most cancer disease sites. And so even with the highest skill level surgeons, there's often tumor cells left behind, and radiotherapy has been integral in the treatment of these brain tumors to mitigate that high recurrence rate. So postoperative radiation is typically delivered at least 2 to 3 weeks postoperatively to allow for healing, and it just does leave in that treatment paradigm, in that repeat surgeries alone are obviously lead to rapid recurrences. Many patients, do not receive that external beam in a second course. Brachytherapy in the brain has been tried several years ago and hasn't done too well because of the high toxicity rates. And chemotherapy and other medical treatments often come up short because it's obviously difficult to maintain sterilization of those tumor cells without advanced local therapy. So people decided to look at this brachytherapy as an option for treatment of brain tumors, and that has really come into fruition with GammaTiles. And so the current standard of care for brain tumors, as we discussed, is maximal safe resection and postoperative radiation. So the first thing we're going to talk about is what these current pitfalls of postoperative radiation can be. And you're waiting to treat these patients. You see a tumor preoperatively, and they go for surgery. They have the 12-hour post-op scan, and sometimes you can see these recurrences as quickly as 3 weeks, which we always hate to see as radiation oncologists, because this does become much more challenging. And we struggle with the idea of whether or not these patients should undergo re-resection. Do we go forward with stereotactic radiosurgery? How do we really address these problems? And often we're guessing at the target. Sometimes there's these situations where we have our post-op scan, like in this 12-hour post-op scan here that we can see the resection bed, but then it collapses down 2 weeks post-treatment. And it's sort of like, well, what do we treat? Do we treat into all this, healthy brain? What do we do in this situation? It can be somewhat challenging. And then we do have problems with dose distribution, in these challenging cases, and sometimes having critical nearby structures such as the optic pathways, as well as brainstem and such. So that leads us to gamma tiles. What are they? Let's start with that. So this is a blown up representation of the tile, and the tile has two surfaces. So as you can see here, one surface is textured. We like to call in the operating room the rough side, or the non-ablative side, as my surgeons like to say, and then the smooth side, which they call the ablative side, and I'll get into why they say that shortly. But this is it's quite small. It's 20 millimeters, and its thickness is about 4 millimeters. Now you can see the actual location of the tiles pretty easily. There's 4 sources within each tile, and they're sort of placed asymmetrically, as you can easily tell, and that's actually done intentionally. And the reason for that is it gives you an option in the operating room, and what I alluded to when I said the sort of ablative side, as my surgeons like to call it, which is the side that's closer to the source, this smooth surface. And that's usually helpful within the OR if you have difficult situations where you have significant gross disease behind, and I'll get into that later. And then you have on the other side of the tiles this 3 millimeter distance, which softens up the heat of the disease of the radiation, and that is on this more textured or rough side or bumpy side. And so that gives you options in the OR. So I always tell people, they first look at this and they think that the tiles are misplacing the source, but it's not. This is quite intentional and very valuable, having that intentionally placed like that. So a little more about the tiles. They are a bioabsorbable matrix. It's a 3D collagen tile matrix. And this, as we sort of already discussed, the structural offset of the radiation sources can help either reduce radiation from direct tumor contact, or by reducing that radiation source distance, or you can increase your radiation source radiation delivery by flipping your source onto this smooth side and getting it closer to gross disease. So that decision can be made intraoperatively, but its design is meant to be put on this textured side. This textured side gives you about 60 gray at 5 millimeter depth after the source has decayed. The decay half-life is 9.7 days. It's our standard cesium-131 source. And, about 95% of the dose is delivered in 6 weeks. We tell our patients after 3 months, you can consider this to be inert. And so the idea being that, you can line the surgical cavity with this tile and obtain a good dose distribution at a decent depth, and get higher dose delivery to the area of the margin intraoperatively. So what are the indications for use? GammaTile currently is indicated as a treatment for patients with newly diagnosed malignant and recurrent intracranial neoplasms. That's the FDA approved indication. This includes high-grade gliomas, brain metastases, malignant meningiomas, any malignant brain tumor, or recurrent intracranial disease. Those are the 2 main indications that are approved. So, you want to obviously consider patients that are a candidate for surgery. Has to be an operable tumor. We definitely want to have those 2. Otherwise, as radiation oncologists, as you can imagine, we'd have quite a difficult time putting in these sources. So you definitely need your surgeon confident in this in the procedure to be able to resect the disease. And we need this adjuvant therapy as a backup. So it has to be a situation where adjuvant radiation is actually indicated and needed. This is just another modality to deliver that radiation. So what are our anticipated uses? So we know that recurrent disease is our more frequent use. We already have a lot of stereotactic radiosurgery experience that has evolved quite dramatically, over the last several years. And brain metastases that need re-resection. They've already had radiation in the past. Recurrent high-grade gliomas, recurrent aggressive meningiomas, or grade 2s or grade 3s that have had prior radiation. Those are difficult situations to treat, particularly with more external beam once they've recurred locally. And there always are these, sort of hodgepodge cases, like these hemangioparasitomas that come up that are recurrent in the brain, or, these other intracranial diseases that continue to pop up. In fact, at our institution, we have a very, very high volume of meningiomas. Our surgeons are sort of world renowned for meningiomas. And so they get these very complex, even though they're grade 1 meningiomas, they're complex location, have recurred several times, have had multiple courses of stereotactic radiosurgery or fractionated radiation. And that's, in my institution, in my practice, that's what we see most often. But there are other situations where we would use it, which would be a little less frequent, but are currently ongoing and studying. So, there's operable brain metastases, typically larger than 2.5 centimeters. We're currently looking at upfront boost for select high-grade gliomas, followed by external beam and temozolomide. We actually have this trial open and are very excited about this trial. Our surgeons are extraordinarily excited because if you talk to any surgeon, it's very frustrating to do a very large maximal safe resection on a GBM and have it recur and then, of course, malignant meningiomas are not, biopsy and have no resection at that time. So typically that's why this malignant meningioma sort of jumps over to the recurrent disease, because often these are diagnosed at the time of surgery, in which case you would not have prepared GammaTiles for the resection. So it's pretty rare for us to get a biopsy of a malignant meningioma prior to treatment and plan for GammaTiles up front, at least at our practice. So that often jumps over to this more frequent side where it's recurrent and has already been irradiated. And then, of course, there's always those other hodgepodge cases that come up that we see every so often. So we sort of talked about what the tiles are. We've talked about what the indications are and then what we expect to use them in. But I think the meat and potatoes of today's discussion is really getting into the workflow of getting GammaTiles started. So the workflow sort of works where you have a patient who's assessed as a candidate, and this is the first point, because every institution is different. And at our institution, it often happens at tumor board where our surgeons will present difficult cases that have already had radiosurgery. And the classic question I get from my surgeons now that we've been doing a lot of GammaTiles is, Dr. David, when can you have the tiles ready? It takes some time to build to that point where they're just, your surgeons are sort of just already asking for the tiles. But that is a developing process. And I would say as you begin your practice in GammaTiles, it's going to be difficult to select the first case. So I do recommend reaching out to the GammaTiles personnel, as well as you can reach out to me or any other radiation oncologist that has experience with GammaTiles and can select a good first case for you. You really want to have your first case as your best case because that builds up the confidence of your surgeons. And once you've built up that confidence, you'll enter into the realm of, hey, when can we have the tiles ready? They're going to learn and know, the difficult cases that have already undergone radiosurgery and really need the benefit of additional local perfect, first patient in your practice. The next thing you're going to want to do is use a surface area margin estimate. Luckily, none of you have to actually do this. This surface area margin assessment, what you'll have to do is just send some representative slices to GammaTiles. We have a formula that we utilize to identify the number of tiles needed. And I will tell you, I have not had a single case where we have overestimated the tiles or underestimated. I've actually been very, very impressed with the formula. It works out pretty well. Luckily, GammaTiles has their own neurosurgeons who can sort of envision what the resection cavity looks like, and that is quite helpful. So they will estimate the number of tiles you need. You put in the tile order. This is often handled by physics, at least at our institution. Our physicists order the tiles. And they will monitor them for when they arrive, and the assessment for once they've arrived. And there's a time window in which it's optimal for surgery to implant them. So you want to make sure that your workflow is set up such that the tiles arrive at the right time frame for when surgery is going to begin. And when you reach out to GammaTiles, they'll help you in coordinating that. The big thing is just making sure you get a surgery date from your surgeon. And the big thing I would say about this entire process that I listed is notice there were only 2 times I mentioned the surgeon, which was patient assessment and surgery date. You want this entire process to be seamless for your surgeons. You want them to have as minimal work as possible, but have as much confidence that everything arrived the way that you've sort of let them know. And that is key to building a successful program, I think. At our tumor board, after our third GammaTiles case, our head of neurosurgery got on the tumor board and said, I want all surgeons to consider this. It's a quite seamless process. All you have to do is tell Dr. David, we need GammaTiles, and it just shows up in the OR. So that's sort of the level of simplicity that the surgeon wants. They already have enough things to coordinate with the surgery itself. So enough on the workflow. Let's talk about the actual implant procedure. The actual implant is integrated really well into the workflow. So what you'll do in your first case is you'll have your GammaTiles rep. They'll be in the operating room. You don't have to sit there for the entire case, I promise. And you can if you'd like to. If you've never seen one of these, it's actually really interesting to go and see the entire surgery from opening to closing. But of course, we're all very busy in our clinics. And so they will sit there and wait with the surgeon, and typically will give you a lead time notification. And you can let them know how much lead time you need. So you can say a 20-minute lead time, 30-minute, hour, whatever it is that you need, they will work with you. And then you'll show up with your physicist, and they'll have their survey meter with them. They'll have the tiles with them, and you'll have the tiles ready. A local GammaTiles rep can walk you through the actual physical steps of getting the tiles out of its container and onto the surgical field. In our institution, we dip our tiles in thrombin. It's often recommended to wet the tiles. So once you show up to the OR with your physicist and you take them out of the container, the sterilized container, you will set them up on a stand, and you want to wet them. You can use normal saline, but in our practice, we use thrombin. Our surgeons have really liked that, as these surgeries can be quite hemorrhagic at times. And then there's no special inpatient precautions after the procedure. Once you've handed these over to the surgeon will place them in the cavity. And post-operatively, there's nothing to worry about in terms of special inpatient precautions, and also special inpatient intraprocedural precautions. You'll find that a lot of people are very worried, but these minutes, so the exposure is extraordinarily low for everybody in the room. And then once your surgeon has placed them, they can continue on with their surgery as previously done. And the best example that you can tell your surgeon is that this is just like laying down dermabond on anything. They'll understand that, and then they'll be very comfortable with it. And that's typically the workflow intraoperatively. So the thing that we always remind our surgeons in the OR is which side is the side that delivering a lot higher dose. So
Dr. David, if I could jump in, this is Sally again. Your audio cuts out every now and then. If you could go back to the part where you said the important thing is to remind your surgeons that.
Yeah, the important thing is to remind your surgeons that the tiles, the rough side is the side that delivers 60 gray at 5 millimeters. Or I like to tell them the less aggressive side, the less ablative side, because that's the side that you're going to want to line the cavity in if there's not any area of gross disease concern. If there is an area of gross disease, don't forget that you can remind them that that smooth side or the more ablative side or the more aggressive side is can be utilized on areas of gross disease. So this is just a little video that they have, of placing the tiles. This the surgeon will do. The surgeon will perform it. You just have to hand the tile over to them, dipped in thrombin. It's quite easy. There's already a tile placed down here. So this is sort of building a sort of a circumferential cavity around the tiles, around the cavity, utilizing the tiles. So you can see you've already got, sort of the bottom of it, and now you're kind of placing the sides of the cavity, aligning it with the brachytherapy gamma tiles. So after the procedure, you'll get a post-op scan. We do in our institution, we always get a post-operative MRI within 24 hours. You can plan off that post-operative MRI, but your hospital administrator might be upset because they want to get the billing charge for their CT simulation. But I often, will give our surgeon an immediate picture, because they're always very interested in knowing what the dosimetry looks like, and they're often very wowed by what the dosimetry looks like. So here you can see just a immediate dose fall off that's just so rapid, and sparing it's sort of normal brain tissue all around. These white little carrots are sort of demarking the actual seeds themselves, and then the red indicating the high dose level and fall off as it gets to green. And then this is sort of comparing to an IMRT or external beam type plan, and what the differences in dosimetry would look like. I always say that the heat of radiation in the brachytherapy is just a lot hotter exactly on the margin where there is the highest concern for tumor cells, which obviously drops off as we get further out. And that's why in our radiosurgery, we don't use much of a margin, because we're really concerned about that disease right along the resection cavity. So the GammaTiles is the perfect solution for that. And trends in the GammaTiles have gone up. So you sort of saw just how useful it can be, and trends across the country sort of mimic that. So from its inception and infancy from 2013 to 2018, there were about 100 cases done. And then now up until 2022, and this is only data through October of 2022, we're up to 690 just in this year alone. So you can see the uptake has been quite drastic, relatively speaking. The other thing that I will note about this trend here is that as you begin doing GammaTiles, at least at our institution and in our practice, we've also seen an increase in just the number of radiation referrals we have. So patients are being assessed more often for radiation. And I have to comment that there is something about showing up to the OR with your neurosurgeon, and sort of physically placing radiation exactly where the surgeon has in mind, that gives them a lot of confidence that radiation is very helpful. So they all of a sudden are thinking about radiation much more often. Remember, the surgeons, they relate everything back to the OR. They look at MRIs, they look at anything, they relate it back to the OR. So now they're relating radiation back to the OR. So we've also seen an increase in just the number of referrals for radiation in general, not just GammaTiles alone. So there is that added benefit as well. So let's get into a little bit of data. I know it's sort of the end of the day. People are probably wrapping up their clinic, so we'll be quick with this. But I sort of wanted to really focus in on the workflows and sort of our experiences. So we'll go through data, but it'll be relatively brief, just because I know everybody's finishing up their day. The first trial, that 2013 to 2018, that was 108 patients that you saw. This is a prospective sort of multiple histology basket design. It was a single arm, single institution study. You can sort of see the numbers of patients and the different diseases that were treated. And basically the trial intervention was maximal safe resection plus tiles, as prescribed 60-day gray at 5 millimeter depth. And the endpoints were local control, overall survival, and toxicity. Now, this representation of the data, I'll sort of explain this because it doesn't make a lot of sense when you initially see it, but I promise it will make sense shortly. This is looking at the patients who had recurrent aggressive meningiomas from that trial that we just talked about. So that sort of grab bag of different patients. As you probably saw on this last slide, there were 35 meningiomas. So they looked at 29 here because they were looking at the patients with meningiomas who had previous treatment, most commonly, which was radiation. So just looking at the patients who previously had radiation for their aggressive recurrent meningiomas, what they did was these 29 patients served as their own control. So what does that mean? So if you look at these blue graphs, let's first look at these. It says previous treatment. So this is saying that the patients who, let's say, had a recurrent meningioma and recurred at 30 months. So this is the recurrence rate at 30 months, having had a previous treatment. So about 38% of them, had local control. The rest were recurring. And those patients then went on to get GammaTiles as their next intervention. And then we were looking at 30 months, how many of those same patients, those exact same patients, recurred. And so, obviously the control went up quite a bit, 77.3%, which it's essentially saying that these patients are serving as their own control. This is the time point at which they failed. And at that same time point, what was their control at? And so, the reason why they sort of thought about it this way is, this was being utilized as a salvage therapy, which is the more common, the more frequent that we talked about as an indication or a use for these GammaTiles. And if this is the setting, we always think of salvage setting as low response rates, but they actually had quite good response rates to the GammaTiles as a retreatment option. Next, a little more data in that study, local control of brain metastases, same layout and design of this of graphical representation. So again, we're looking at patients as their own control. Now, of course, it doesn't go out to as many months because often patients with brain metastases have a competing risk for death. But you can see these local control rates are quite high, at the resection bed. So, you can get some pretty good local salvage option here with the GammaTiles. And then lastly, this study is a little unrelated to the previous, but I threw this slide in here. This is its own separate study, recurrent GBM versus current treatment. So we're looking at recurrent GBM, which I know a lot of us probably struggle in our practices, because there's not many great options. You can give the patients Bev, which often works as sort of like a super steroid is how we think of it. You can try to re-resect, try things like Optune. Some patients opt for no treatment. And we know most of these patients don't make it out for more than a year without any other option that can help salvage that well. And then, these GammaTiles patients did much better in this, sort of retrospective cohort. So this was not a prospective study, but, does provide confidence that we are making some headway. Next, I sort of wanted to go over some of the adverse events in these studies, and this, this is going to be a big question for your surgeons. Your surgeons are going to really want to know what their adverse event rates are, and as you can see with the GammaTiles, it's not any different than the previously reported surgical literature on wound infection, closure issues, or hematoma. It's about in the same ballpark that you would expect with any neoplastic surgical resection in the brain. And then, as radiation oncologists, we always want to know what are our rates of toxicity as well. What's our radiation necrosis rates? So, traditional brachytherapy in the brain from many years ago ranged anywhere between 18 to 48%. And back then, we were sort of putting just direct seeds into the brain, no protective layer for the very high dose areas, which led to these very high rates of radiation necrosis. But now with GammaTiles, it's down to 8%. And I always sort of say this with a little asterisk to remind people that many of this 8% is in patients who have had previous radiation. Actually, this data comes from all previously irradiated patients. So, I would say SRS rates of radiation necrosis are, in the same ballpark or higher. And particularly higher though when we talk about re-irradiation settings. So the GammaTiles do serve their brachytherapy dose fall off clinically as well. So clinically we're seeing the benefit of that extreme dose fall off. And the fact that it's a low dose rate, so it's delivering it slowly over time. So that is also helpful. Lastly, we're just going to go over ongoing trials. I will sort of speed through these as just as a consideration for your practices and as you start up, if you want to consider adding these trials into your program or sending patients for these trials. So there is a registry trial. We participate in this, and this is going to be a 600 patient multi-center observational using real world data. So, these are the anticipated disease sites here. And it's going to be sort of a basket design for all patients receiving GammaTile, so we can really identify, and mine, this large registry to answer questions. As you can see, the outcomes included below, and we expect to follow out to at least 5 years with interim analyses and multiple publications planned as well. Next, there's an MD Anderson trial. I'm actually very excited about this trial. We do not have this trial open, but I like the idea of this trial. therapy for large newly diagnosed brain mets. So large defined as 2.5 centimeters to 5 centimeters, and up to 3 additional unresectable lesions treated with SRT. So essentially, if you had 4 lesions, one was a large lesion, the other 3 were small lesions. You, in one arm, you'd treat all 4 lesions with stereotactic radiotherapy, and the other arm, you'd still treat the small 3 lesions with stereotactic radiotherapy, but that one large lesion would get GammaTiles instead. As we all know, these large lesions can be very difficult to control, and unfortunately, we're limited with external beam options as as the size within the brain goes up. For some reason, our dose goes down, and we all know the reason is to prevent necrosis. But again, control rates obviously go down with that as well as you start to decrease your radiation dose. So this does give you an option to increase that dose. So we are very excited about the outcomes of this study as well. Next, there is a trial going on at Memorial Sloan Kettering. It's a single center trial. They are looking at the treatment of recurrent previously irradiated metastases planned for resection. So the comparison of surgery plus GammaTiles versus surgery alone. So this should give some interesting data, on local control rates. They're looking to follow that out for 2 years. And then lastly, we sort of talked about this trial briefly. We have this trial open as well. This is GammaTiles and newly diagnosed GBM. So they're looking to get about 60 patients on this study. This is a feasibility study. And the idea here is patients get surgery, maximal safe resection, followed by external beam and temozolomide in one arm, and in the other arm, they are going to get maximal safe resection plus GammaTiles plus external beam and temozolomide, but we are going to reduce the external beam dose. So we're going to get rid of that boost. So the external beam dose is only 46 gray instead of the 60 gray. And so we are excited about that, as GBM is difficult for all of us to handle. So in closing, the key conclusions, from this is that GammaTiles is FDA-cleared radiation option for newly diagnosed malignant and recurrent brain histologies. The early clinical data is promising. The trend, of its use is promising. It's covered by Medicare and most private insurances. It's an area where patients have very limited options. This is a promising strategy. It does give the patient, sort of this one and done treatment. They just come in for surgery and radiation all at once. They go home and they can focus on recovering. There is minimal side effects, and there is reduced treatment burden, time, travel, and cost. So that's the end of the presentation. Feel free to ask questions. I'm interested to hear what people have to say. Thank you very much.
Thank you so much, Dr. David. Again, this is Sally with the Medical Society. If you have a question, please either drop that in the chat or raise your hand, and I will unmute you if you can't unmute yourself, and go for it. Nicole Bono, Dr. David, wants to know what CPT codes are used for brachytherapy.
It's a great question. I'm a physician. I don't know too much about CPT codes, but my team, or probably GammaTiles, even better, would be able to answer all of those questions. Unfortunately, I'm not too privy to that knowledge.
She says she didn't expect you to know. It's some parts just don't need to stick, right?
Yeah.
Hi, Nicole. We could follow up with a coding and payment guide with you. Has all those codes listed out.
Great. Thanks so much, Ashley.
Thanks.
All I can tell you to answer that question is it has been profitable at our center. I know that because my administrator tells me that. So there is a way to make it profitable. That's about the most I can say.
We have a question from Corey Thomas. He says, what have the successes that you have seen with GammaTile use been with your patients?
Yeah, that's a great question. So in our patients, we started GammaTiles about 1 year ago, close to 1 year ago. And in all of our patients thus far, we have not had a single recurrence, which is great. However, I will say we did have 2 patients die of complications, but those were not related to GammaTiles at all. One of them died 90 days post-operatively from a PE. So I would not attribute that to GammaTiles. And then the other one died of a massive hemorrhage less than 24 hours after surgery, which my surgeon was already concerned about from the beginning before the surgery to even started, and counseled the patient several times about it. So both of those cases, barring those 2, we actually have had no failures thus far.
Great. One more from Leighton Pang. What's the largest cavity that can be treated with GammaTile?
Good question. The largest cavity I think that we have done at my institution, I think, was about 7 centimeters, quite large. You'd be surprised about how big it can get, but maybe somebody from GammaTiles has a larger cavity that they've experienced. But in our practice, that's what we've had.
Great.
Our largest was 18.5 tiles, a really giant meningioma.
Wow. That kind of answers the next question from Isabel. She says, what's the maximum number of seeds or tiles that you have placed with confidence?
Yeah, I mean, and that I think we ended up placing like 8 or 9 tiles. I can't remember. I've not placed 18, but you know, clearly can be done.
Gotcha. Let's see. Another question. They are coming in now. That's great. How do you handle cases where patients had prior SRS and it's unclear preoperatively if there's a necrosis or recurrent disease?
Oh, that's a very good question. So yeah, so what we'll do, obviously, we'll do MRI perfusion scanning to try to help identify if it's disease or not. But yeah, these are challenging because you know, you kind of have to be prepared with the tiles, and if the pathology comes back negative for malignancy, so they'll do a frozen at the time of resection. If that comes back negative for malignancy and confirms necrosis, then of course we don't place any tiles. Then the case is canceled in terms of the GammaTiles. So that's been our approach previously. Now our surgeons have recently suggested, how about we resect these patients, and if it comes back malignant, we'll continue to close observation. When they need re-resection again, then call for the tiles. That way we don't have to abort a case. Now we have not tried that yet. I'm just telling you that's an option that we are considering currently. But right now, if we were in the OR and we had tiles ready and the patient did not have confirmed malignancy and they had necrosis, we would not proceed with tiles.
Okay, thank you. And Richard Crownover asks, how does the formula estimate the cavity shrinkage for brain mets?
Oh yeah, so it actually doesn't really. It's the formula is not for shrinkage of the cavity. The formula is for intraoperatively what the size of the cavity will be. Now, I think your question is probably getting at, as the cavity sort of resorbs, what happens? Well, as the cavity resorbs, the tiles themselves, that collagen is bioresorbable, so it's going to resorb with the shrinkage of the cavity. And so what you end up seeing is you sort of see the tiles slowly getting closer and closer together. But they're obviously depositing their dose, and at 1 month, 90% of the dose is already delivered. So by the time they kind of scrunch together, it's already delivered most of its dose.
All right. Any other questions? I do not see any raised hands. Anyone? All right, well, I will say that that will conclude the Q&A portion of the evening. And I will follow that up by saying, if you have any questions that we did not address, or if I cut you off too soon, just email anybody that you know at ACRO and ask them to get you to me, Sally, and I will put you in touch with Dr. David so that you can ask that directly from the source. With that, I will thank all of you for your time. Dr. David is not wrong. It is, it's a long day every day, right? So thank you so much, Dr. David. Thank you everyone for being here, and we will see you next time. Thank you so much. Bye-bye.